Welcome friends to the new episode of our YouTube series How Do Expert Manages It. Since the videos are posted on YouTube, one can watch and listen it as and when time permits them. Our today's topic is antiphospholipid antibody syndrome. The expert faculty today is Dr. Manisha MOTERIA. Dr. Manisha MOTERIA has passed her MD Gynec from Gujarat University with 4 gold medals. She is a senior consultant obstetrics and gynecologist at Rajkot with special interest in infertility and high-risk pregnancy. She is a present president of Rajkot Obstetrics and Gynec Society 2020. She has attended many numbers of national and international conferences as faculty. She is a recipient of Young Scientist Award from ROGS, actively participating at public awareness programs regularly. She has published various articles in national and local medical journals and health bulletins. At present, she is a director of Krishna Hospital, Rajkot.
Hello friends, in this video, we will discuss antiphospholipid antibody syndrome. As in our day-to-day practice, we come across more and more patients with bad obstetric history in terms of recurrent miscarriages. In earlier year also, Shilpa Shetty, as shown in this slide, has shared that she is also having antiphospholipid antibody syndrome. Because of that, she is suffering from miscarriages and she had a nice daughter with surrogacy. So what is antiphospholipid antibody syndrome? It's an acquired autoimmune disorder characterized by the presence of antiphospholipid antibodies with vascular thrombosis and or associated with recurrent pregnancy losses, and there will be a placental insufficiency in case of pregnant females. These are autoantibodies that react with epitomes on proteins that are complexed with negatively charged phospholipids. We can see 15 to 25% of the patients with recurrent pregnancy loss having antiphospholipid syndrome, out of which 15% are having first trimester loss after establishment of fetal heart rate in first visit. There is 2% prevalence rate in low risk obstetric women is there. We can have a successful pregnancy outcome only in 10% of antiphospholipid syndrome patients. So this is considered to be a very high risk group of patients. We can classify antiphospholipid syndrome into 2 main categories. One is primary, second we can consider is an secondary. In primary, there will be mainly autoimmune diseases will be there, that is systemic lupus erythematosus, rheumatoid arthritis. There will be systemic sclerosis. In diabetic patients, there will be autoimmune diseases, Crohn's disease, and sometimes in autoimmune thyroid diseases we can see APS. In secondary cases, there may be some kind of infective diseases such as syphilis or HIV. There can be a drug-induced antiphospholipid syndrome. Few malignancies such as carcinoma of ovary or carcinoma of cervix or lymphomas can lead to secondary APLA. Sometimes long use of oral contraceptive pills also leads to antiphospholipid syndrome. What will be the catastrophic events in antiphospholipid antibody syndrome? There is rapid organ failure due to generalized thrombosis and high risk of death. In pregnancy, we can have a risk of pregnancy-induced hypertension in 15 to 50% of APLA cases, out of which 15% are severe PIH before 34 weeks of pregnancy. Risk of intrauterine growth retardation is 30%, and other risks such as preterm labor or maternal thrombosis is also there. When we need to test our patients, there are few obstetric indications such as unexplained stillbirths, recurrent pregnancy loss, or there is an unexplained fetal death in second or third trimester, if there is an intrauterine growth retardation in past pregnancy, or if there is a severe pregnancy-induced hypertension before 36 weeks of gestation or 34 weeks of gestation, there are placental abruption in past pregnancies. There are few non-obstetrics indications such as autoimmune diseases such as SLE, unexplained thrombocytopenia, hemolytic anemia. If there is a history of stroke from 25 to 50 years of age, means perimenopausal, in false positive serology test for syphilis. In this case, we need to test for APLA. There is revised Separo classification criteria for APLA. We can judge our patients by two criteria. One is clinical criteria and second is laboratory criteria. In clinical criteria, we are supposed to see about vascular thrombosis or pregnancy morbidities. In vascular thrombosis, if there are one or more clinical episodes of arterial, venous or small vessel thrombosis, we have to consider our patient for investigations. In pregnancy morbidity, if patient is having one or more unexplained death, or we can say missed abortion at or beyond 10 weeks of gestation, or there are less than 34 weeks of gestation premature birth of morphologically normal fetus because of eclampsia, severe eclampsia or placental insufficiency, or we can categorize third into a 3 or more unexplained consecutive spontaneous abortions before 10 weeks of gestations. In laboratory criteria, we can go for 3 tests. One is lupus anticoagulant, second is anticardiolipin antibodies, IgG and IgM, and third is anti-beta-2 glycoprotein 1 antibodies. What are the clinical criteria for vascular thrombosis? There will be more of venous thrombosis than arterial thrombosis. Mostly it is seen in lower limb, deep vein thrombosis. Any part of venous system can be involved, that is portal, renal, mesenteric or intracranial veins. Untreated risk of recurrence is 25% per year, and this risk increased by 5 to 12% in pregnancies and postpartum period, when it is mostly associated with lupus anticoagulant and anti-beta-2 glycoprotein 1 antibodies. Arterial thrombosis is mainly seen in middle cerebral artery, which results in transient cerebral ischemia or stroke. Other manifestations of arterial thrombosis is subclinical myocardial ischemia, stroke, or there will be a transient ischemic attacks. In general, lupus anticoagulant has higher specificity for thrombosis than anticardiolipin antibodies or anti-beta-2 glycoprotein. Lupus anticoagulant is more specific but less sensitive than anticardiolipin antibodies and anti-beta-2 glycoprotein 1. Some patients may have all the 3 antibodies, and due to transient positivity, we can see positive antibodies in patients. In anticardiolipin antibodies, most commonly detected using enzyme-linked immunosorbent assay. Recommendation is to measure IgG and IgM isotypes. Both in IgG GPL and IgM MPL should be greater than 40. Lupus anticoagulant is identified by APTT, KCT or PCT, and it is misnomer associated with thrombosis rather than anticoagulation. Anti-beta-2 glycoprotein 1 antibodies is like anticardiolipin antibodies. Both IgM and IgG isotypes should be measured. Result should be greater than 99th percentile. Practice points for laboratory testing will be those patients with thrombosis, measuring IgM antibodies does not add useful information. Those having pregnancy morbidities, the role of IgM antibodies is unclear. Testing for IgA antibodies is not recommended. Now we will discuss management of APLA. Dear friends, we have to take detailed history of each and every patient when they enter in our OPD. So review patient clinically, take proper history and review her perfect medical history. Documentation, the confirmation of persistent antibodies is must. assess her for renal function test and rule out thrombocytopenia or any positive family history of same. Even if there is no evidence of SLE, go for lupus anticoagulant, anti-cardiolipin antibodies, anti-beta-2 glycoprotein 1, sometimes anti-RO and LA is also advisable. If thrombotic event has occurred in last 6 months, tell her to postpone her pregnancy for next 6 months. Postpone pregnancy if SLE has been active or patient is hypertensive. Review for other rheumatoid factors and make sure that warfarin is substituted by heparin at the time of her first missed period. We can achieve highest success rate with a combination of unfractionated heparin and low dose aspirin. We can start 150 mg of aspirin, which improves pregnancy outcome by selective inhibition of TXA2 and thus restore balance with prostaglandins. Dose of unfractionated heparin is 5000 units. If patient is obese, we can increase up to 7500 units subcutaneously twice a day since pregnancy test is positive. There are few complications with heparin such as bleeding, hypersensitivity, thrombocytopenia and osteopenia and vertebral fractures. If you put your patient on heparin, please increase the doses of calcium to 6 mg BD with vitamin D3 also. Thus the effective alternative to heparin we have to found, that is low molecular weight heparin. So in day-to-day practice, most of the consultants are using low molecular weight heparin nowadays because it is to be administered once daily and there are less risk of osteoporosis, less risk of thrombocytopenia, and we need less intensive monitoring of such patients. So nowadays, low molecular weight heparin is an emerging treatment of choice for recurrent pregnancy loss associated with APLA, and prophylactic dose is 40 mg subcutaneous once a day. There is no role of corticosteroids or IV immunoglobulins therapy to improve the live birth rate. SHAH guidelines are that if patient is having 3 or more recurrent pregnancy loss plus lab test positive for APLA, administer low dose aspirin before conception and prophylactic heparin starting at the date of positive pregnancy test. Recommendation by RCOG is again same, treatment of combo is better than aspirin alone. Both of them have a common saying, corticosteroids and IV immunoglobulins do not improve live birth rate in such patients. So dear friends, what is the take-home algorithm for such patients? If patient presented with prior history of thrombosis when she is non-pregnant and on warfarin, you have to switch her to therapeutic low molecular weight heparin in pregnancy. If patient came with previous history of pregnancy morbidities, you have to advise her low dose aspirin preconceptionally, that is 150 mg. Along with that, once pregnancy is confirmed, you have to put her on low molecular weight heparin. And if there is an antiphospholipid syndrome with no thrombosis or no any pregnancy morbidities, you can only go with low dose aspirin. So what is take home message? If there is an obstetric complication in past pregnancy with no history of thrombosis, you can advise her low dose aspirin preconceptionally, then you can add low molecular weight heparin once patient become pregnant. If there is an incidental finding of antiphospholipid syndrome with no any clinical complication or criteria, no treatment in preconceptional period, once patient become pregnant, you can add low dose aspirin. If patient with history of prior thrombosis, you can give low dose of aspirin with low dose of aspirin and low molecular weight heparin once she become pregnant. Now, what is the management of antiphospholipid syndrome patients with pregnancy? You need to go for an early confirmation of cardiac activity and follow up USG scans around the time of previous losses. Early dating scans for confirmed diagnosis of fetal growth restriction, so we can serially monitor that patients accordingly. 3 to 4 weeks growth scan for early detection of fetal growth retardation. In later stage, you can surveillance the fetus with non-stress test and BPP after the period of viability with DFMC. So now what is the management for delivery purpose? Whether we should go for cesarean section or whether we should go for normal vaginal delivery. We can pull on this patient till term if there is no any associated obstetrical complications. We can stop aspirin at 36 weeks. You can continue low molecular weight heparin till woman goes in labor or one night before planned induction or elective cesarean section. Though literature says vaginal delivery is preferred, but with past complications or we can say previous pregnancy losses, patient is never ready to take any chance, and because of that cesarean section rate is slightly higher in our day-to-day practice. LSCS may cause peripartum thrombosis, so we have to take care of that part also. Epidural anesthesia is contraindicated if there is thrombocytopenia, but if fresh reports with all CBC and parameters are normal, you can give spinal or epidural anesthesia. There is no complication reported in last few researches. Let's discuss few points regarding postpartum management and what will be the best contraception for patients with APLA. In post normal delivery, we can advise patient an early ambulation. In post cesarean section patient also, early ambulation is always advisable, but you can give pneumatic compression stockings if patient is obese and hypertension. Restart aspirin after delivery. Restart heparin according to pre-delivery doses. If there is a history of thrombosis, full anticoagulation for 6 weeks postpartum is advisable. Breastfeeding is safe if on aspirin and heparin. If patient is on cytotoxic medications because of secondary APLA, you can tell her to avoid breastfeeding. Calcium supplementation is must as long as his heparin is advisable, but you can tell her to take calcium supplement during lactation period till 6 to 8 months of lactation. In contraception, we have to tell her that during whole life you are not advised to take estrogen containing oral contraceptive pills. So she can go for only progesterone pills or intrauterine contraceptive devices. She can opt. Barriers we can recommend her, and she can have an history that she have to remember that I have this kind of complications. So at the age of 40 or 40 plus, no gynecologist is advisable to give her hormonal combination pills. So dear friends, what is our take-home message? Women with recurrent pregnancy loss before 10 weeks of pregnancy or fetal loss more than 10 weeks of gestation should be screened for antiphospholipid antibody syndrome. Do a screening for antiphospholipid syndrome who have prior unexplained venous thromboembolism either before or of new onset in pregnancy, and those who have a history but not tested yet. Antenatal administration of heparin combined with low-dose aspirin is recommended throughout pregnancy in antiphospholipid antibody syndrome pregnant patients. Combined approach, always seeking opinion of physician, rheumatologist and hematologist. And believe me patient, if you counsel your patients with bad obstetric history that this injection will give you a healthy fetus, you will not require NICU admission. She will be definitely ready to take injection till 36 weeks or 38 weeks of gestation. She cannot take estrogen containing oral contraceptive pills in future life also. So be APLA minded. Always consider your patient for same, investigate properly, treat properly and counsel properly. Then and then your patient will go happily with a healthy baby and healthy mother. Thank you, friends.
Thank you very much, Dr. Manisha, for a very interesting and educative talk with slide presentations on our day-to-day practice. Please like the link and share it to your friends, your colleagues and students. Please subscribe this channel. Thank you.